everyone. This is Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening and viewing EP Talk, the place for emergency physicians, aka ER docs, come to talk about things that are important to us. Sometimes it's professional, sometimes it's personal. And my guests today are Andrew Phillips and Dr. Mark Langdorf. And we have an interesting topic today. It has to do with another journal, another publication, not too dissimilar from, well, it is a little dissimilar to Emergency Physicians Monthly, but tell me a little bit about the journal that you all are involved in. Andrew, you start, and then Mark, you can add your 2 cents worth.
Sure. So this is the Western Journal of Emergency Medicine, and it is unique among several of the emergency medicine journals because it is open access, and it is sponsored by a variety of the emergency medicine societies. ACOEP, ACEP, CalACEP, and CalAEM are among the sponsors, in addition to a lot of the academic programs that are out there. So it's a very diversely supported journal, and
Andrew, is this a print journal or is this just online? Tell me a little bit more about the journal itself. I mean, how long has it been around? I mean, EPM has been around for 25, 30 years. What about Western Journal of Emergency Medicine?
Yeah, it's a combination of the two. It's primarily online, but there are some print issues. And actually, for those questions, Dr. Langdorf is the editor-in-chief and has been with it a lot longer than I have. I'm grateful to be able to be a part of it. I'm one of the associate editors. So let me actually, Dr. Langdorf, this is your baby. I'm going to kick it to you. Why don't you share a little more about it?
Sure. Thanks, Mark, for having us on the podcast. This is my first podcast, so bear with me if I'm a bit nervous here. We're joined in the background by my dog, Jake. You can see him on the chair to my left. Hopefully he won't disrupt us too much. Anyway, the Western Journal of Emergency Medicine started as the California Journal. It's 22 years ago. Dr. Antoine Kazi and Dr. Bob Derlett from the University of California system started a newsletter, which started out as 4 pages. Fast forward 10 years, and we created the Western Journal of Emergency Medicine in 2007. And it's important to recognize that we have a subtitle, which is Integrating Emergency Care with Population Health, meaning that we're the public health emergency medicine journal, and we're interested in systems of medicine. If you give me a drug company study of, drug A versus drug B in asthma, I'm not very interested. But if you give me algorithm A versus algorithm B treating a population of sickle cell patients, then that's the kind of thing we're interested in. So it's emergency department operations, it's workforce issues, which we'll get to in a minute. It's computers in medicine, technology, focusing on ultrasound and newest technologies that we can use to influence groups of patients in the population health. Of course, during the pandemic, we have had lots of submissions and publications related to how do we take care of populations of health, and that has naturally led into inequities in healthcare, and the journal has published many articles about how the delivery of healthcare is inequitable in the United States especially, and what can we do about that. So we had a special issue recently on gun violence injury prevention and research, and we have a planned special issue next year on social emergency medicine. And so those are the kinds of things that the journal focuses on, and we're not into drug studies, but we are into how do you take care of populations of patients in the emergency department before they get to us and after they leave our confines. What's the best way for the system to integrate with emergency care?
Now, are you, just as a matter of disclaimer, are you associated with any particular group, a large national contract management group, association, ACEP, AAEM, any of those, or is this something? It was it's kind of like when you mentioned something. I remember Antoine Kazi years ago when I started Emergency Physicians Monthly in, gosh, the late 80s. Our first official print publication was, I believe, in 1992, but we had actually been several different iterations of that prior to that. But I remember the Western Journal coming out not too far after when I launched EPM. So Western Journal was Antoine Kazi's effort, and along kind of a different line than I did. But I just want to know your affiliate. Is there any kind of affiliation with the Western Journal?
Sure. So we're proud to have affiliations with all of the emergency medicine organizations in one form or another. So we are officially sponsored as the National Journal from the American College of Osteopathic Emergency Physicians. We are
Okay.
sponsored by California chapter of ACEP, California chapter of American Academy of Emergency Medicine. We
Oh,
produce, along with CORD, the Council of Emergency Medicine Residency Directors, and the Clerkship Directors in Emergency Medicine, special issues on education and research.
that's
And
cool.
we have an agreement through the Social Emergency Medicine special issue with the Society of Academic Emergency Medicine's consensus conference on that topic that was held last May. So we are independent in that we don't have an allegiance to any particular organization, and we work cooperatively with all of them. And basically, the goal of emergency medicine is to be, what can we do as a group of emergency physicians to help our patients better? And so we're not beholden to any particular organization. In fact, we're independent enough to not have to ask anybody's opinion or board of directors' opinion about something like, what do we call ourselves? So moving into the topic at hand, emergency physicians are a unique and wonderful breed. I've been an emergency physician for 33 years, almost all of that time at the University of California, Irvine. And thank you to that department I used to chair. Nice to get financial support from the department you chair, but now Dr. John Christian Fox is our chair, and he continues to support the journal. And the point is that the journal is independent of any of those political issues. Now, the word provider is problematic.
Now you're launching into the thing that caught my attention. Actually, I think I got the email from Andrew. Did I not? That the Western Journal had decided to make a kind of I wouldn't say literary change, more like a nomenclature change, and it caught my eye, and that's the reason for the podcast tonight, because I wanted you guys to give some background about the Western Journal, and I know it's been around a long time. You're not actually telling me anything new, but for our readers, and particularly the younger and the listeners and viewers, some of the younger guys may not be all that familiar if they're not from the West Coast. With the Western Journal. It's been around a long time, and it's performed a very, very important independent function, as Mark, as you're saying. And EPM has a certain co-heritage with the Western Journal. I mean, Antoine Kazi's been a friend of mine for a long time. I've admired him. I don't know if he hasn't been a personal friend, but I've admired him and the work that he has done. And so when I heard from Andrew that you guys had made a fundamental change in the nomenclature of provider, I said, I want to know more about it. So I'm going to throw it back to you. I don't know, Andrew or Mark, you guys decide how you came to this change and what does it mean?
You were on a roll. Mark, why don't you start?
So just to continue, so emergency physicians are so unique and special in the house of medicine and also in society. We are the guardians of the shallow end of the gene pool. It's been said. We take care of everybody who who nobody else wants to take care of. On nights, weekends, holidays, we sacrifice our time, our family, our health at times. We put ourselves at risk to take care of patients. And we went through a tremendously rigorous training program to become an emergency physician. And so I'm proud of that. I'm proud of having trained 150 residents when I was residency director, and proud of having chaired the department for 20 years. And to mix up our credentials and our commitment to the patients with anybody else who didn't go through those rigorous training hurdles that we did is denigrating to our specialty. It's denigrating to our psyche, And there's been tons of talk and things written about burnout in emergency medicine. One of the components of that is professional respect. And
Yep.
emergency physicians ought to have the highest level of professional respect. And because we've gone through the training we did and we have the commitment that we do, to lump us together with people with less training and less commitment is harmful. And
Yeah.
it contributes, in my view, to professional dissatisfaction and burnout.
Yeah, you have to ask yourself the question at the end of the day, why did I do all this? I just went through this. I mean, I graduated from medical school in '79, which was the first year of the conjoint board exam, and then so took my boards for the first time in 1982, probably pretty close to when you did, Mark. And so I recall, as you do, those early days in which we really struggled. I mean, fought legal battles and social battles is maybe the wrong word, but we worked long and hard to get the respect that was due for the hours, as you say, and for the hard work that was being done. And I just generationally just have recently gone through the same cycle with my son-in-law. My daughter married, oddly enough, an emergency physician, and he's finished his training and finished his now a fellowship in ultrasound, or is finishing an ultrasound. And I don't think these young guys understand, and I'm not diminishing anything about my son-in-law, but generationally they don't appreciate the hard work that went into giving them the respect, the compensation, the ability to do the procedures and things that they're able to do today that we were not able to do. I recall having surgeons step in and say, "I'll take over here," in my emergency department that I was the chairman of, and tell me that they were going to do certain things and that please step aside and just walk in as if they owned the place. And then years later, having a surgeon actually stop me and say, "Thank you for what you do. You're obviously an expert in what you do, and I will always back you up." I thought, whoa, when did that happen? Well, it happened over about a decade, maybe even longer, maybe 2 decades. And we have come to the point of not only being qualified, but also providing quality care. And now the public really expects that. And that's the key. That's the key. And that's the reason why this idea that you guys came up with for some reason, maybe it was the insurance, maybe it was government, I'm not sure exactly how, we sort of gave this generic term, provider. Well, what the hell is a provider? I mean, are we all kind of lumped into this same pool? I mean, I'm not against what are what used to be called physician's assistants, who then have changed their name to physician assistants and now apparently are called physician associates. I'm not against that, okay? I just want the public to be clear about the training that those individuals have had and their responsibilities, and particularly the responsibility for medical care that's being provided in the emergency department. I've taught at PA schools, and I have great respect for them, but at the same time, I do feel that there's a certain amount of creep and that's going on in the nomenclature, and that's why I was interested in hearing what you guys had to say about provider. That's the reason why we've kind of been lumped in as providers. There's a lot of different people who are called that. I'd like for you guys to kind of talk about the various levels of people who have been lumped into that title of provider.
Andrew, go ahead.
Yeah, so I was gonna say one of the reasons this even started to come to my attention was I received a note from we'll say an unnamed university setting where I had a note from my provider, one of those inbox messages, and it was from a dietitian, and it just kind of struck me that previously I had gotten these notes, it was inside the provider inbox sort of thing, from physicians who I'd seen and such, and occasionally from others, but particularly including someone like a dietitian, I started noticing that, there's mention now of EMS providers, and the definition just starts to expand. And when you start to look at the literature and where it is, and in fact, we were mentioning where does it come from? Yeah, I think it was the 50s, but it was decades ago in the federal law with Medicare and Medicaid, CMS. And in fact, it just refers to an individual or an institution that receives funding from CMS. So when you're mentioning a provider, yet now the insurance companies and the folks, some of the entities that are creating how we use language have shifted away from that. And in fact, there was an article, I'm blanking on where I saw it, but one of the big insurance companies is making very clear, like we're not providers, we are whatever XYZ insurance company, which is quite a deviation given that really in the beginning it was in reference to institutions. The first of the references were institutions. So then you start to see some of the societies speaking out against this for various reasons and various forms. The first of these that I've been able to track down in terms of actually making a decision not to use a term was the American Academy of Family Physicians, and that was a good 20 years ago. Very close, actually, to at least when they announced it it wasn't even an announcement. It was a side comment, an editor's note inside of a viewpoint or an editorial sort of piece. So it wasn't even one with a big fanfare of such. None of the other journals that I've seen made a public and central decision, and I don't want to say fanfare, I just want to say I think a public acknowledgement, a reckoning of the importance of language in that term, for a lot of reasons that I think improve what our journal is conveying. If you're as a research journal, it's important, I think we'd all agree, that people understand what the specifics are of your study. And in particular, this comes out when, for example, the special issue for CDEM and CORD, when we're seeing the word provider, that we're looking at 15 providers with ultrasound and how good are emergency providers, if you will, at ultrasound for appendicitis. I'm just kind of making this up as an example. But, well, okay, what are emergency providers, right? Like that makes a big difference when you're talking about the very strict requirements that residencies have now to credential their residents, physician residents. Well, that's another word, right? That side conversation about residents are not all physicians now because the word has been co-opted, and there was a scathing editorial from the various educational societies. But at any rate, that makes a difference. And we're talking strictly from a scientific perspective of if we're going to say what is the sensitivity and specificity of POCUS for appendicitis and the ED, you can't use a word like provider. And it's not knocking in any way the different skill sets of the various members of the team. It's just a reality of what is the background of the individual that you're testing. I mean, the whole point of looking at POCUS, right, with emergency physicians or anybody in the emergency department is because they're not RDMS certified. You're looking at the educational difference. That's the point of looking at POCUS. Can we, with a different skill set, do a point of care ultrasound that ends up having a similar sensitivity and specificity to someone who's RDMS credentialed and a radiologist, board certified radiologist, looking at those images? The education and training and background makes a difference in the ability of that particular tool to be useful. And
Sure.
so if for no other reason, you have to be accurate. Sorry, that was a rant.
If I could make the dummies, the dumbed down version of just what you said is, if you're looking at how good are providers in reading wet reads of radiology films, and you include all kinds of people who have all kinds of levels of training, it's going to be a very different result than if you're simply looking at the results of the readings from board certified emergency physicians. Very simple.
Because there is nothing more regulated and scrutinized then physician training and
Yep.
physician residency training. I was a residency director 15, 20 years ago, and the requirements to be graduating a resident were very nebulous. These days, a resident graduates and they've been through so much scrutiny and judgment and evaluations and testing that that matters. The
Yeah.
person who graduates from an emergency medicine residency now has orders of magnitude at times the training and the mentorship of some of the other people that are considered providers, and they are considering pharmacists and respiratory therapists, as you said, paramedics, nurse practitioners and physicians assistants, and dietitians as providers along with the institution that employs them. And the other dynamic that's going on is the push for those less qualified, less trained physician assistants and nurse practitioners to practice independently without
Right.
real-time oversight by board certified emergency physicians. And that is a disservice to the patients and disservice to society to hold oneself out as qualified to treat a patient independently without the rigorous training and certification that emergency physicians went through. So the whole
Right.
thing is very confusing, and it allows those entities, those institutions that employ providers to get away with staffing, in this case, emergency departments, with less qualified mid-level practitioners, not necessarily supervised by emergency physicians real time. And that's a
Right.
crime.
Right. Mark, you and I have been around long enough that we've been through the I wouldn't say the wars, but the discussions where people who had various other kinds of training, the whole practice tract qualification discussion that went on for, gosh, a decade, because that door was left open for a very, very long time. And when do you finally close the door to practice tract? On the job training. Okay, let's just talk about practice tract. It is on the job training. You could be anything you wanted to, 40 years ago when I started. There were emergency docs who had no training. There were emergency docs who had dermatology, family practice, a variety of other things. Very smart, very smart. I'm not denigrating anything about them whatsoever. But you just didn't know what you had. You didn't know what you had. And so we left this practice tract door open for a long, long time. And then finally, at some point, out of a desire to just simply make sure that the public knows what they're getting, okay, we said the door now is closed. There's probably smart folks out there who probably could have gotten in, but now the door is closed. And you cannot become board certified by any other means than by going through the rigorous training that, Mark, you've just spoken of, and be mentored, examined, scrutinized, trained. We're not going to certify anybody else besides the people who have gone through that. And now we are coming, we've taken this term and we've kind of lumped anybody who happens to be in the emergency department for various reasons, doing various things, as providers. Well, maybe generally they are providers in some sense, but it is just a way of muddying the waters to say, who is my doctor? Who's my doctor?
And this topic, oh, sorry, go ahead.
Yeah, no, I'm just simply saying, we as professionals, we look at it and it sounds like it's just a turf war. We want to make sure that we get paid for what we do. We worked hard for it. We want to get paid for it, that sort of thing. I look at it from a patient's perspective, and to say, somebody is telling me that I have cancer, that I have appendicitis, that I need to go in and get, surgery, that I need to, start on, who is this person? Oh, they're your provider. And I think, what? Wait. Who's in charge here? Who's ultimately responsible? who has the training to tell me that, yes, that I need to have this tube stuck into my chest, or that I need to go and get, surgery? Who's provided, who's the expert?
Who's suturing up your laceration? I mean, something very simple. Who's draining your abscess? I mean, those are things that are, drilled into us about how to do that right, and not so with the other providers without such training.
Right.
As an
Right.
example, I was president of the medical staff at my institution for 2 years, and president and chair of the credentials committee before that. And one of the issues that our big institution is doing is hiring nurse practitioners and physician's assistants, because there's too much clinical care to be delivered. And a lot of the clinical care is not necessarily requires a physician's judgment or time, and the documentation requirements are enormous. And there aren't new residency slots cropping up everywhere. What there are the need for clinical care. So the solution to that in our institution and others is to hire mid-level practitioners, nurse practitioners, and physician's assistants. And the credentials for those folks came to us as a credentials committee as part of the medical staff, and they said, we are applying for these procedures. And I said, okay, knowing that the training of those practitioners are not the same as a physician, please fill out this form to tell us how many of these procedures that you're requesting privileges for to practice independently on our patients have you done in your training? And the answer was zero, 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 because they were mostly new graduates coming out of training programs with very little clinical hours required, or certainly not procedure training. And so now, in order to qualify those privileges, they have to go and get real training somewhere. How they do that, I don't know, without doing a residency somewhere where they're actually going to do those in simulation or on patients. But had I not stood up and said, how many of these have you done in your training, they would be credentialed to perform those procedures on patients with no training and no experience.
None
and that's
whatsoever.
part of the confusion that we have between physicians and all the other people who want to treat patients.
Right. No.
Amazingly, this is a third rail, right? What we're talking about is just numeric. How many of these things have you done? What are the credentials that you have? And we all know we have to wear badges in the hospital, right? It's a requirement of what's your name and what are your credentials. And yet it's very much the third rail to be talking about staffing and independent practice. And these are very heated discussions.
Right.
Part of that is why, if you look through the editorial, and when we discussed actually this editorial with the other editors, some comments were made. We didn't go into the independent practice, we didn't go into the supervision and such, and we were very intentional with that because we felt like we all ought to be able, all of us, physician assistants and nurse practitioners, anybody under that umbrella provider, ought to be able to agree that it's important that that the patients know who's taking care of them and to be referenced by the specific credentials that you have. And in fact, if you look at the APA website and the ANP, their preference when they talk about, for example, the ANP has a policy saying that their preference is not to be called mid-level providers, and go into a discussion of that. But part of it, at the very top of it, is that the preference is to be called nurse practitioners, and the preference for the physician assistants to be called physician assistants. And so why not the preference for physicians to be called physicians? There's one of the points that I really like that AAM did recently was a position statement on the term provider. At the very beginning, the premise of that statement was that AAM believed that it was not just a legal obligation to inform patients of your credentials and who you are, but an ethical one, that patients should know who's taking care of them, to your point. And so we figured it should not be controversial, and yet it still kind of is. It should not be controversial for us to be very specific in the journal of who exactly is this study about. And we reflect the language, right? Part of the impetus for this is that people are reading journals, or reading that language, and the word just propagates. We have a responsibility to the readers. That includes medical students, that includes residents. They're reading this. We're setting in print the language people are going to be speaking at bedside. And it's incumbent on us to provide a language, I'm using the word provide for provide a language, but to be delivering a language that is effective and proper, something they can use. And ironically, it's almost setting the clock back, right? Because that was the term that was most often used, physician or doctor or whatever. But to be fair, physician's more accurate than doctor, right? There are lots of people with doctorates.
Right.
It shouldn't be controversial, and it is.
All right. Yeah. I know it, and unfortunately, Dr. Langdorf, I happen to disagree somewhat. I don't think this is a matter of requiring, that we have to have NPs and PAs doing this work. I don't believe that. In my understanding of the workforce issues that we have going on right now, there are board certified emergency physicians who are available to do that work, and that groups are preferentially using them, using physician assistants and nurse practitioners for financial reasons. And I do not believe that that is in the best interest of the patients. I think that they deserve to have someone who has greater training. If they elect to have a PA or an NP to take care of their problem, that's fine. I think they should have that option. Don't misunderstand. But to be misled or to assume that they're the same or that they're being supervised when they're not, I think we are doing a vast disservice to the patient, and actually many times to the mid-level provider. I don't want to insult anybody, but the PA or the NP who's providing care. And so I think that we have plenty of board certified emergency physicians. That's my point.
Yes, and let me agree with you. When I was talking about medical staff, I wasn't talking about having mid-level providers do those procedures in the emergency department. These were the intensive care unit places that wanted to have physician extenders, for lack of a better term, to write notes and round on patients because there weren't enough residents left anymore to take care of all the sick patients. And so, yeah,
Okay.
so I certainly agree with you that in the emergency department, the emergency care team must be led by an emergency physician. They can supervise directly other less qualified, less trained clinicians, but it needs to be led by a board certified emergency physician. And my point was that graduates from these training programs for PAs and NPs had not had any clinical training whatsoever in the procedures they were applying for to do procedures. And my first thought was, why would we need a lesser trained person to do a chest tube or a central line in an ICU at all? Why wouldn't a physician do that? And if we don't have physicians to do enough lines, then we got a problem with training our physicians, not by bringing up people who need to have, all new training to start to learn how to do these things.
Right. Yeah, I couldn't agree with you more. And particularly, I'm old enough to have elderly parents who have been in those ICUs, and to know what I expect as far as level of training and expertise, and then to find that the person who's actually providing the care is someone who's directly out of a lesser trained program, is disappointing, to say the least. And sometimes, in fact, pretty frightening to think that that's what we've gone to. So I agree with you. I agree with you. And in our emergency department, this idea of providers, one of the most, you mentioned procedures, but one of the most complex things we actually do is diagnostic workups and thought processes. And I am flabbergasted at the variety of skill that is evident in some of our physician extenders. Some I would work with as fellow physicians, and many of them I've encouraged to go back and go to medical school, and they have, and I've supported that. And on the other hand, I've had some that clearly were not up to the diagnostic process, and their only reflex was to order more testing and go by protocols. And I think that the public deserves more than just simply reflexively going through, the Merck manual or whatever. Remember the little book we used to carry around that had the workups, and as an intern, I would thumb it out. Okay, belly pain, they get this,
The Washington manual.
washing manual. Yeah, and you fill out all the various tests that are required, and I mean, because we didn't know any better, you got it all, and I think that that's where we're at right now, and that's part of the cost and of that's going on in medicine by people who don't have the experience and diagnostic acumen to do what they're doing. So.
Yeah, and so again, just to reiterate what Dr. Phillips said, this is a reason to change for our journal because language matters. What we say and what we write and what we read influences our opinions going forward. And so our journal is independent enough to not have to ask the board of directors of any organization and to say, this is the right thing to do. Yeah. Physicians are physicians, and all the rest of the practitioners are what their credentials are.
I applaud you for what you're doing for the integrity of being clear. I'm not putting down physician assistants or nurse practitioners. I'm just simply saying that we owe it to patients and to providers and to emergency physicians of every sort to be clear about, and especially in an academic journal like yours, to be clear exactly what we're dealing with. And so I thank you, and I thanks for the really fruitful discussion we've had this evening. And I hope that our listeners will take a look at this. If you have some things you'd like to sound off about, be sure to write editor at Emergency Physicians Monthly or me directly at mplaster@epmonthly.com, mplaster@epmonthly.com. And I'll be happy to discuss these issues, and we might even publish them. If you have something else you'd like to do to comment about, I'll be happy to invite you on the podcast and we can talk about it further. But thank you, Dr. Langdorf and Dr. Phillips for the evening. And
if nothing else, my dog Jake now understands the reason to use the term physician, an emergency physician.
Okay, thank you, gentlemen, and I look forward to it. And for all of our readers and listeners, thank you for joining us at EP Talk tonight. Again, I hope that you'll continue listening to this podcast and respond with your comments. Thank you.